proteinuria. Actually, it is equal because it means that macroalbuminuria is the same as proteinuria, and because we have some methodological problems to detect protein or albumin. This is the reason why we divide that. So in a normal way, if I ask you what is the normal level of proteinuria, the correct answer is that we excrete a small amount of albumin and no amount of protein. So we have several types of proteinuria. There are some which could be announced as transient. So usually what is the most important to know that this transient proteinuria means that the workload of the glomeruli is increased, and due to that also the burden of the filtration of protein is increased. And it's very typical situation for physical exercises, but also for other situations like a fever. It's a matter of truth that the amount of protein which is excreted is quite low, so even less than 0.5 gram per 24 hours. What is important to add that we have normal blood urine sediment. Then we have so-called the orthostatic proteinuria, which is a sign of the young age, and it is connected with the prone position and laying and standing position. So this is also something which has to be correctly examined. And then we have the pre-renal proteinuria, which means that this is something like an overflow. So we have a lot of protein which go through the kidneys, through the glomeruli, and due to that, this protein is excreted. One of the typical situations is if there is paraprotein or paraproteinemia, which results in paraproteinuria. But there are also some other proteins which could be excreted, and it's written here that should be hemoglobin, which is basically also protein, but almost only a small amount. The much higher amount of myoglobin can be excreted due to the rhabdomyolysis, and also acute inflammation, for example, which is displayed here. But the most important issue is that we have multiple myeloma issue, which is connected with paraproteinemia and paraproteinuria. And then we go on, because we have the renal origin proteinuria, which is basically glomerular or tubular. And concerning glomerular, we can divide that in a selective or non-selective proteinuria. And selective, what is important to add, that only small proteins such as albumin are excreted. So let's say the damage is considered to be not so harmful for the glomeruli. And non-selective means that the holes in the membranes are larger. So due to that, also the larger proteins, like globulins, are lost. And of course, it's a sign of more, let's say, severe damage of the glomerular membrane. And it's a good example for proliferative glomerulonephritis, like, for example, IgA nephropathy, which is the most common one. Then we have tubular proteinuria, which means that the proteins are excreted via tubular cells. And it's a typical sign of some situation. I would say that the most typical one are the nephrotoxins, for example, as aminoglycosides, which are antibiotics, which bear a very high nephrotoxic potential. But also there is a Fanconi syndrome, which is one of the inborn or inherited kidney disease, or belong to these sort of groups, and the loss of protein could be, let's say, low, but with typical proteins like which are listed here. The most typical one is alpha-1 microglobulin. And then we have post-renal proteinuria, which is very heavily connected with the inflammation in urinary tract, or sometimes with neoplasia, but basically it's a sign of urinary tract infection. Well, we have something which can be called like a quantification of proteinuria. So there are no strict rules. What is important to say that the most important is nephrotic range proteinuria, which is above 3.5 grams per 24 hours. This borderline was agreed arbitrarily. So simply it was one day agreed that this is something which is dangerous for the glomeruli, and this is the reason why we stated the border like that one. The moderate proteinuria is between 1 to 2 grams, basically, and mild proteinuria is below 1 gram or sometimes below 0.5 gram per day. Then we have to qualify the proteinuria and quantify the amount. So the easiest way is to use the dipstick testing, which could be routinely performed in the outpatient practice. And it's important to say that there should be some limitation concerning the quantification, because you know that we have only semi-quantitative scoring, like from 1 to 4 crosses. And also the problem is that this methodology is not designed to detect immunoglobulins in principle, because it's much more designed to detect the albumin. Then the other issue is spot urine analysis, and we have two types how to examine that. It's protein creatinine ratio, PCR or UPCR, and albumin creatinine ratio, which is mostly used in the situation like, for example, is the evaluation of the diabetic glomerulosclerosis. The advantage of this examination is that we can use the spot urine. Usually we take the morning sampling urine, but sometimes you can take also the during day sampling. Then we have 24 hours urine collection, which is a very difficult discipline because all voiding samples should be collected, which is not so easy. And due to that, there is a problem about the validity of this examination. And furthermore, it is not so easy if you became older and handicapped. So this is the reason why mostly in the routine practice, this methodology is not frequently used. But we as nephrologists prefer to do that because you gain a lot of other information, for example, like the amount of urine, but also you can gain the knowledge about the different ions or other different, let's say, substances which are excreted in urine. And then we have the typization of proteinuria. And for all proteinuria examination, we use the alpha electrophoresis. And this electrophoresis can help you what kind of protein is excreted. So you can find out if the main issue is because due to the albumin loss or if the globulins are lost. So this is one of the methods how you can distinguish between the glomerular and tubular proteinuria. Well, I've been already talking about the microalbuminuria, which is basically from the terminology point of view wrong, term or incorrect term, because we do not have any kind of microalbumin. We simply have only albumin, but the amount is so-called micro. So it's from 30 to 300 milligrams per 24 hours. And it is a good indicator of vascular damage. So that's a reason why so many cardiovascular patients have these findings, because they suffer from cardiovascular disease. And I have said that the vascular endothelial dysfunction is behind that. And basically, albuminuria is considered to be a strong prognostic marker for the progression of any kind of chronic kidney disease. And there are some other facts which are listed in the connection with microalbuminuria. Well, then we have the issue of hematuria. Hematuria means that we have microhematuria or macrohematuria. Microhematuria means that in the urinary sediment we can find out 5 or more red blood cells per one field or high-powered field. And this is basically the definition of hematuria. But as I said, we have macroscopic or gross hematuria, which means that the blood is visible in the urine. So the color of urine became red or sometimes brown or sometimes dark if it is, let's say, stored for a longer time. But basically, it's a good sign for tumors. Here is listed also the hemoglobinuria, which is basically rare. This is also listed with the use of some drugs. But what I cannot find here, beside the tumors, is the problem of the lithiasis, so nephrolithiasis, or let's say the urinary tract lithiasis. So there is a damage which is done by the stone inside of the urinary tract, and the final results can be the macrohematuria. And the third reason when you can find macrohematuria is the certain type of urinary tract infection. Like the most typical example is the hemorrhagic cystitis, which is closely connected with the infection of the urinary bladder. So microscopic hematuria is important clinical symptom, which is usually connected with also other signs of the kidney disease. One out of them could be hypertension or decreased renal function or proteinuria. But basically, we also have the asymptomatic microscopic hematuria with proteinuria, which is basically the sign of the glomerular disease. And of course, you first should prove that the origin of hematuria is from glomeruli, and I will have a talk about that later on. And then we have something which is called as an asymptomatic microscopic hematuria. And if you have something which is just a single issue like proteinuria or hematuria, we call that like isolated. So isolated means that this is only hematuria without proteinuria. And one out of the reason is the benign or so-called benign macrohematuria, which is closely connected with the IgA nephropathy on one side, and on the other, it is connected with the thin glomerular basement disease, which is very frequently inherited disease, and behind that is that the glomerular basement membrane is thinner, and due to that, the erythrocytes are passed through the membrane. So we can prove them like being glomerular microscopic hematuria. Well, and then we have the causes of hematuria. So one out is renal, which means glomerular or non-glomerular. So for us, as nephrologists, it's more important to prove the glomerular origin erythrocytes urea. And basically, these are connected with the proliferative glomerulonephritis, and IgA nephropathy is one of the most typical out of them. Or RPGN, rapidly progressive glomerulonephritis, is another issue where the crescentic necrotizing glomerulonephritis is present and very heavily damaged the glomeruli. And then we have non-glomerular renal causes of microhematuria, which is mostly connected with the tubuli or interstitium. And I already been talking about the infection, about the nephrolithiasis or tubular interstitial nephritis or ATN, acute tubular necrosis, which is based on the acute ischemia of the renal cortex. The most common reason is hypotension, which could be systemic one, for example, in MI or in the other circulatory problems. And the extrarenal causes are listed here, like calculi infection and the others. So again, we have several opportunities how to diagnose. One is urinalysis. So we've been talking about the dipstick. So they are basically the same criteria which are true also for proteinuria. What is very important is the phase contrast microscopy, because with this examination you can prove the glomerular origin of the hematuria. And the principle of this examination is based on the fact that if erythrocytes is passed through the glomerular membrane, then the erythrocyte is damaged concerning the shape of the erythrocytes. And there are some typical findings where the shape produce so-called acanthocytes. And acanthocytes are believed as erythrocytes which were passed through the glomerular membrane. And if you want to say that this is positive, so there is a glomerular bleeding, then the amount of acanthocytes should exceed 5% out of all red blood cells in urine analysis. Well, always when we have the patient with hematuria, we should not omit the coagulation tests, because of course if there is a, for example, clotting disorder or these kind of problems, or the thrombocytopenia or the other problems with the coagulation cascade, then of course one of the sample is the bleeding to the urinary tract, so we can detect the hematuria. But furthermore, we should use a lot of serological testing, because we would like to find out what is behind that, particularly if we are considering the glomerular origin of erythrocytes urea. And then we simply are talking about the immunological panel. And there is important to find out what is the level of the Ig, so immunoglobulins, IgA, IgN, IgG, IgE, and the others. Antistreptolysin is not so much important, but we should consider to test the antibodies panel. And one out of them, the most important, are ANA, so anti-nuclear antibodies, and double-strand DNA, both belonging to the systemic disorders like lupus nephritis. Then what is not written here is anti-GBM, so anti-glomerular basement membrane disease antibodies, which is typical sign of pulmorenal syndrome or good pasture syndrome. And then the last one are ANCA, so anti-neutrophil plasmatic antibodies. And we have two out of them. One is P-ANCA and the other are C-ANCA. Both are connected with the ANCA-associated vasculitis. And of course, we have to perform other, let's say, routine examination. One out is urine culturing, because I've been talking about the UTs. Cytology is important if you consider the neoplasm, because particularly the papillocarcinomas of the urinary bladder can be discovered by this examination, and further imaging studies, like the most important one is ultrasound, but also CT. And cystoscopy is belonging to the hand of urologist, and it is particularly important in case that there is the bleeding from lower urinary tract. Three-tube test is rather old-fashioned one, but basically it's based that if you have three tubes and the voiding is according to the timing of the voiding, then the first 15 milliliters represent the urethral bleeding, then the final one is representing the upper part of the urinary tract, and the bladder is something between. So basically I went through all the presentations, which was rather short, but now I would like to switch to the panel to be able to see you. I don't know if I will be successful, but now the lecture is open for discussion. So I don't know how many out of you are now connected. I can see the number of 21. So please, if you have any question, try to type them on the screen or unmute your micro and ask openly. So now I'm waiting for your possible questions. I don't know how to switch off the screen. Well, what I said, can you hear me, please? I hope, yes. So what I said is about the acanthocytes. This is the examination which is designed to prove the passage of erythrocytes through the glomerular membrane. So basically, you will prove the glomerular bleeding or glomerular erythrocyturia or glomerular hematuria, because it's a matter of truth that 99% of the patient who approach you in the outpatient praxis are connected with the subglomerular erythrocyturia. So we have to find out where is the origin of the erythrocyturia. And on one side, you can manage the whole urological workup, like, for example, the biochemistry, the culturing of the urine, then the sonography, the CT, or the cystoscopy. And if all these results are negative, then you can think about or consider the glomeruloerythrocytes or erythrocytes. But to shorten that long way, you can use the phase contrast microscopy, which is basically the urine sediment examination. And we are looking for so-called dysmorphic erythrocytes, and I explained then one out of 10 of them are called acanthocytes. And this is the typical shape of these acanthocytes, which are somewhat smaller compared to normal erythrocytes, and there is something like a nose of this, let's say, membrane problems. So the shape is different, and if you find out 5% out of them in the phase contrast urinary sediment, then we believed that the origin of erythrocytes are from glomeruli. Is it clear what I said? Yeah, okay, perfect. No. What I can now see from Ines or Ines, well, don't omit that definition. This is too precise, because first you should prove what is the local lab so-called normal range. Here in the Vinohrady hospital, we even have higher amount. So it is up to 10 red blood cells per one high power field. So you should check it how it is. Basically, what I did not stress is that it's rather difficult to quantify the amount of microhematuria, because a small amount means that there are about 10 to 20 erythrocytes per one field. Then say something like a middle, which is, let's say, 50 to 100 cells in one high power field. And there is a heavy microhematuria, which means that there are about 150 erythrocytes per one field. And all above, it's considered like a macrohematuria. So you can see that the color of the urine is becoming red or dark or brown. So basically you can confirm that visually, so you can see it, right? And in the past, we used different methodologies, right? Like Hamburger sediment or Attis sediment and the others. But finally, these sediments are not used anymore. Yeah, basically concerning the proteinuria, well, if you use a normal biochemistry, it's true what is written here. So the albumin should be up to 30 milligrams per 24 hours. It's considered like a normal albuminuria, and everything above is microalbuminuria. But concerning the proteins, if you use high-powered alpha, then even you can distinguish a small amount of globulins. But if you use any other methodology which are routinely used to detect proteins, we call that exton, this examination, that the borderline as being normal is considered 150 milligrams per 24 hours. So the correct answer is, if the question is there any kind of physiological proteinuria, then you can answer yes. If we consider albuminuria, we have so-called normal albuminuria. But to find out the globulins in the urine, it's not normal. It is basically proteinuria. It's okay? Perfect. So are there any other questions? Probably not. So thank you very much. And I am not quite sure if there will be follower of my presentation because we have had some problems with the connection. So what is simply true that the other presentations are or should be all loaded in the portal of VUCA. Well, there is a question concerning 3-tube test. It's old-fashioned test. So it's really designed for a very basic condition, and you should not use that in the routine practice. It's inaccurate. Perfect. So thank you very much for listening to me. I hope that you joined some knowledge, and if you would have any specific question, or if you have any specific question, you can contact me via email, and probably I will be answered I will be able to answer. Okay. So thank you very much. Have a nice day. Bye-bye.